Welcome to Sports, Clicks, and Politics with your hosts, Ben Hussong and me, Shawn Hannon. Welcome to another episode of Sports, Clicks, and Politics. This is a very special episode, an extra episode, a guest interview episode. With us today, we have Andrew Doe. He is a board-certified, fellowship-trained vascular and interventional radiologist at Alate Health in Houston, Texas. And Dr. Doe, I want to welcome you to this program, and thanks for coming in.
Thank you. Thank you very much for having me.
Let's do a COVID 101 if we could. What do you know about the virus, or what do we know about the virus? What do we know at the beginning? What have we learned along the way? And what do we know where we're at right now?
So let me preface the whole conversation by the fact that, I don't think COVID or the coronavirus, this basically the most correct name is SARS-CoV-2 because it looks much like the SARS we had back in 2009. But let me preface it saying this is a real disease. This is a very serious disease. This is a deadly disease for the certain people. But it's very similar to other infections we've had as far as the virus. We understand how the virus gets into the cells, and we've slowly been learning how the virus affects the body. So basically, the virus itself gets into the cell through a little thing called the angiotensin receptor. And that's a very important receptor for physicians because that's how we control blood pressure. Most of our drugs work with that receptor. So this coronavirus that gets into the cell starts to get, like any virus, gets us to make more coronaviruses. And then eventually our body starts to fight it. And what we learned kind of midway through was it wasn't the virus that was causing all these patients to have this severe respiratory issue. It was our reaction to it. It was called a cytokine storm, or it is called a cytokine storm. So basically our body just overreacts to this virus being there. And if we look at the sickest patients, their viral count is actually very low, but their immune response is very high. That was the first thing we noticed. The second thing we noticed was when we got these patients that got this respiratory issue, typically when you see this, and you can see this kind of thing with anything, with the flu, with a common cold. I can think back to 2006, my first patient as an intern, young lady on the floor, maybe 30 years old, had a cold a few weeks before, came in, a little bit of trouble breathing. So the ER admits her. And I'm thinking to myself, young, healthy lady, she got a cold. What are we worried about? And within 6 hours of her being on the floor, the nurse calls me and says, she's really having trouble breathing. I've got the oxygen on the way up. What do you want to do? And I thought to myself, boy, this is odd, being a naive intern. So I called my senior resident and he said, get her to the ICU. And what she's experienced is what we call SARS, severe adult respiratory syndrome, or with this virus, it's just severe respiratory syndrome. We still keep the A in. And what happens is with these patients, these common cold ones or these flu ones, these patients, the lungs get very stiff. You can't ventilate them. You have to push the air in under high pressure. And when you do that, you can keep the oxygen up, but it's not a very good exchange and the body's not doing well. The coronavirus or the COVID-19, when this happens, for some reason, we couldn't figure out early on why these patients, the lungs would move normally. They didn't have any issues with that. They weren't hard to what we call ventilate. We could give them all the oxygen we wanted, and the blood oxygen levels still wouldn't come up. And then we figured it out that it wasn't like these normal viruses that make the lung tissue act poorly. It's actually causing clotting in the veins that take the blood away from the lungs back to the heart so it can go to the rest of the body and bring the oxygen there. So this was much different than anything we had seen. Like the history of man, simple viruses mutate, They go from one species to the other, and they get us sick. And this is no different. The big difference with this virus, other than how it causes the disease, is the people it affects. And I don't want to sound morbid or unfeeling here, but in the strictest sense, if you look at the virus itself, it's population control. It kills people that have other underlying issues, or people that are over the age of about 60 is the biggest category of patients that are the highest risk. It is almost undetected or unnoticed in patients 24 years and younger, which is very interesting. So we have this virus that really only affects the old and the infirmed, and then the rest of the population has very minimal effects from this virus. So that's basically where we are now, and we've kind of figured out which drugs are helpful, when they're helpful, and we're definitely improving upon our treatment of these patients. There's still people dying, but it's getting less and less every day.
Did the use of ventilators change when the realization that it was acting differently than other coronaviruses? Did that stay the same, or was there something that was changing along the way, I guess?
Yes, we initially, when we saw what looked like this ARDS syndrome going on, now we tend to intubate later on, realizing that we've got to get the inflammation under control. They probably won't need intubation. So there's a lot more patients in the ICUs that aren't actually intubated. Whereas with a flu or any other kind of viral ARDS syndrome, we intubate earlier. So it has definitely changed the need and the use of ventilators.
Okay, and you had brought up the seemingly devastating effects on older people, but the lack of even noticing it in younger people. I'm going to kind of take that into where we're going in the fall here with the chance of schools not reopening across the country. I believe New York State, where we are, is going to attempt to open some kind of a hybrid version here. What do you say? Like, are kids, teachers safe? Like, what would you suggest for parents and teachers and anybody else whose lives depend on these schools reopening in the fall? Is there risk? If there is, what is it? And what's the risk of not going back to school?
So there have been multiple studies, and like I said earlier, you can see a lot of different countries have come to the same conclusion that right around mid-20s is the cutoff for these patients. 90% of patients 24 years of age and younger have no symptoms. Now, the difficulty there is trying to figure out the transmission pattern. Because they don't have these symptoms, are they still as likely to transmit? My advice, and in Texas, we're doing a hybrid model as well, basically doing online schooling my advice was to my brother, who's a school teacher in the state of New York, and my other brother, who's an administrator in the state of New York school system, would be to take you know who your teachers are that are at risk, that fall into that high risk category. And you either furlough or you sabbatical them, and you get someone in to replace them or to take their spot for a certain time until this passes, until we're kind of either at a herd immunity or we have an effective treatment for this. And then they come back and teach. Personally, I'm not worried about the kids. My daughter's going to go back to school. I'm not worried about it. The young, healthy teachers, they shouldn't worry about it. If you fall into that high-risk group, then you probably shouldn't be teaching. If you have high-risk people at home, then you should probably, minimize their contact with the kids. If it's possible, grandma, grandpa, aunts, uncles kind of stay away and self-quarantine. But as far as the school age population and the younger teachers, I don't think there should be any worry or concern about going back to school.
Dr. Doe, you brought up the idea of herd immunity, and I think that's what a lot of people are hoping for will be the return to normalcy. The most common avenue that people are thinking is a vaccine. Can you talk a little bit about whether the vaccine is the end-all, be-all, or what are the different avenues that we could achieve herd immunity and the pros and the cons?
If we look at where we're at right now, as far as percent recovered and mortality rates, we're actually right around the flu, which has a vaccine. So I don't think a vaccine, especially in the short term, is going to be the answer or even be possible. I think we have a better chance of hitting that herd immunity. And especially once we get a better idea of how kids transmit this or do kids transmit this from person to person, the best thing they could do is go back to school, because these young kids giving it to another young kid that is 90% are asymptomatic, that's how you're going to reach herd immunity. This is what South Korea did. For me, they're the best model of how to react to this. If you're sick, stay home, self-quarantine. If you have underlying medical conditions, stay home, self-quarantine. If you're much older, stay home, self-quarantine. But the rest of the country goes back to normal. And, maybe screen a little more for temperature and exposure, but don't shut down the whole economy because you're worried about a few people getting sick. I think you're starting to see Sweden hit a herd immunity. And if you look at Sweden versus Finland, one shut down the school system, one didn't. And there's really negligible difference between the two in the outcomes and the mortality of this.
So you're in Houston, which is, perceived in the media at least to be a hotbed. You, along with Florida and Arizona, seem to be the three states, Texas, that is being the three states that get brought up the most as far as when compared to how New York, specifically where we are, handled the virus. You guys are, perceived to have blundered, if you will, or at least going down the wrong path in those states, even though the data doesn't necessarily suggest that you, it suggests that you are handled it much better than our governor in our state did. Give us a view of what's happening in where you are in Houston, what you hear, what else is going on in Texas, and if you have some observational comparisons between how Texas and New York has handled the situation.
So the great thing about where I am in Texas, because anyone can see this, anyone with a smartphone can go to Google and look up Texas Medical Center real-time COVID stats, and you can have them. And it'll show you not only how many COVID patients are there, it'll tell you what percentage of the ICUs the COVID patients are taking up. It's out there. It's very open. Now, as far as how we've dealt with the infection and how the press is perceiving that, there was an internal communication between the major hospitals and the medical centers, and they kind of shot themselves in the foot, and they kind of started, they kind of let out information that was easily misinterpreted. And basically what they said was our ICUs have doubled percent capacity in only a few days. Well, first off, the ICUs in the medical center want to operate 90 to 95% capacity. And that capacity is the normal capacity, not the total capacity, not total possible capacity. That's their normal operating capacity. So when they said they doubled in only a few days, they actually went from 40% to 80%, which you think, wow, that's horrible. But no, they want to be at 90 to 95% because that's where the hospital is generating revenue and they're in good standing, financially. So as the percentages went up and people kept looking and looking, they started to publish more and more. Oh, this hospital's at 102% capacity. Well, first of all, if you're at 102%, you should realize you're probably not seeing the true numbers. What does 102% mean? Well, it means they had to go into some of those reserves and use a few beds there. But the percentage of COVID patients in these ICUs never topped 30%. So, And
is there, piggybacking on the rooms specifically, are there staff to be able to, make sure that these rooms are appropriately being handled as well?
Absolutely. The big thing that we did because of this, this worry about the capacity of the ICUs, the biggest thing we did in Houston was we went back and shut down elective surgeries again. So now you've got all those staff that aren't doing elective surgeries, caring for those patients either preoperatively, postoperatively. So you've got a lot of free bodies. And as much as the press tells you these hospitals are just overflowing, and they tell you the morgues are overflowing, well, you can call any funeral director and ask them, hey, are you at capacity? Do you have more than you can handle? And they'll all tell you no. And if you talk to any, people that go in and sell things, reps that sell things within the hospital, they come to my office and say, hey, you have any cases, because the hospital's dead, they're not doing anything. So this idea that it's, we have bodies in the street or whatever they want you to believe.
I'm just waiting for a new set of those little crazy little nurse videos where they're kind of floating around on gurneys and stuff. Isn't that supposed to happen on a national level? Because I think that was happening here. So
yeah, I did see some of those. You think to yourself, if it's that bad, how do they have time for that?
Fair question. Dr. Doe, help me understand, what would it take to overwhelm the health system where you are? I mean, I'm getting the impression from what you're saying that you're not close. Numbers are coming in, that you're getting more and more positive tests. What would it take? Like, how far away are we?
Well, the Texas Medical Center, and again, you can check this data if you want to, but the Texas Medical Center ICU status, we're probably about half of what our total capacity could be.
Okay.
And as we test more and more people, as we see a lower and lower mortality rate, it would have to be an astronomical second wave to overcome our capacity. And not only that, if we're at half capacity now, if we shut down hospitals for nothing but COVID, we're probably at a fifth of total capacity. So we'd still be able to increase what we can do. And I don't think we're going to see it. And I feel like the narrative in the press has shifted to, all of a sudden it was, look at how many people are dying from this. And then you realize 32,000 deaths in New York State, and we have 3,900 deaths in Texas, even though we were open and far less restrictive. And our number of cases is going through the roof. Well, as we get more tests, as we have a lot of these numbers that are coming back are fall into two categories. They're PCR tests that were performed 3 to 4 months ago that take that long to come back. And the other thing, that there was just a kind of Texas Medical Association, Texas Medical Board kind of came down hard on these testing sites, because you pull up in your car and you get tested and you're positive, and they say, come back in 2 weeks. And when you come back in 2 weeks, they test you. Well, they count that as two positives. So, the numbers are definitely inflated. And we've had many instances of, these testing kits sent back with someone's name on it that was never tested, or people waiting in line to these testing centers that filled out all the forms but got sick of waiting and left, and they're getting calls and letters in the mail, hey, you tested positive, when they never actually had a test performed. So we're seeing a lot of that. And San Antonio just retracted, I think, 3,400 cases or 3,100 cases that were probable COVID positives.
So I want to revisit what you just said on the mortality rate is dropping. And I think for a lot of people, you think whatever the mortality rate of a disease is, it is. That's something that is sort of fixed. Can you go into what's causing a mortality rate of this virus to drop as time goes on?
Well, two things. One, hopefully we're getting better at treating this, and I think we are. And two, we're becoming more aware of just how extensive this disease is and how much earlier we were actually seeing this disease than we thought we were. There was a physician who's basically takes care of pilots. I'm blanking on the word.
Medical examiner?
Medicine. No, not that kind. No. So he's kind of like an occupational physician, and his main patients are pilots. Had about 9,500 pilots that he takes care of. And he's estimating back in August, these pilots, since they were moving internationally, going to China, going throughout Asia, that these pilots were coming down with something. They were testing negative for every flu, for every kind of different, viral infection. And they believe that these 80% of these pilots that were getting sick were probably COVID patients. So it was probably around in August of 2019. And we're starting to see the number of people that were exposed to it. We're starting to see the number of people that actually have it. And that's driving the total number of cases up, whereas the number of patients dying, especially when we label them correctly, is dropping. So we're seeing this big drop in mortality, and that's what's happening.
And I was going to say, and so let's go back. So you're saying these pilots may have had this, or at least maybe symptomatic, maybe as back as August. Well, that kind of messes up messes up, but it kind of extends the timeline from some of the information we were getting out of some of these countries early on, specifically China, whereas the birth of this virus. So if it was being spread by pilots in August, I'm guessing that it was either, available in China at that point and has been spread long before we had anticipated or thought it did.
I think, excuse me. I think if you look back at the timeline and the most difficult issue with the timeline is China being a reliable source. Exactly, for the information on this. We know for a fact that they saw their first patient long before December 31st, which was when they reported seeing their first patient. I think it just got to a point where it was out of control and they were unable to cover it up, that this was happening. And I think it's realistic to say it probably was there much earlier than December 31st or even December. That we were seeing cases, but the most difficult part is going to be, again, China being China and not telling us the truth as to how many cases they're seeing. Taiwan, they were reporting some strange pneumonia far before December. I want to say early November, end of October. So there's evidence there. We're never going to really know when this started, but we do know when it got out of hand, and that's when China probably started being honest with the WHO and with the world.
Can we put honest in air quotes?
Absolutely.
So I think it's becoming more and more obvious that the virus is highly contagious, easily transmissible from person to person. What are the most common means of the transmission? Like, am I more or less likely to get it by sitting here with Shawn? Am I going to get it walking to the grocery store? Like, where? I know it can happen anywhere, but what are your most likely outcomes there?
So the best indicators we have, looking at all the evidence and different, Canada's come out with studies and different sources of studies are looking at this transmission. The most likely scenario is prolonged person-to-person contact, half an hour or so in very close kind of space with another person. Canada, British Columbia, they looked at the epidemiology of the spread and they feel that it's not an airborne transmission. It's a droplet transmission. So you have to, basically someone's got to sneeze in close proximity to you and you've got to be, rubbing your eyes or, those types of things. It's not like it's just floating in the air and everybody's going to catch it.
And how long does those droplets last in the air? Is that a known number?
So Stanford's done excellent work on their virology department on the life of this virus. They've shown 30 minutes in UV light kills the virus. Temperatures, I'm blanking the exact number, but above 70 degrees for about 60 minutes kills this virus. Direct sunlight can kill this virus in 30 minutes or so. So we know that this isn't a very hardy, very difficult virus to kill. And most surfaces, even cardboard, the virus doesn't live very long, especially if the temperature's high enough. So as expected, warm weather and sun. You guys ever get that in New York?
Actually, the last few for this month, whatever, I don't know. Other than the actual virus, the weather here has been pretty good. I have to say, for upstate New York, yeah.
We were about 95 today.
Yeah, we had a heat index of 102 today, so it was Texas hot.
Yeah, hopefully by September we can get below 90. So,
and And following up on the droplet thing, I think this might be an easy way to, if there's something that we should talk about with masks and the transmission, if it's being transmitted through droplets.
So this is proving more difficult to disprove. I don't like to say anything without some good evidence to back it up. And what we're seeing more now, as far as transmission goes, it looks like you have about a 24 to 48 hour incubation period before you're seeing symptoms. Started out, we thought it was as much as a week. We thought patients were spreading it during this asymptomatic period, but it looks like the new data looks like 24, 48 hours, and then you get symptomatic. And we know from any virus, you can spread it when you're symptomatic. The question is, can you spread it in that 24, 48 hours where you're not showing symptoms? And we don't know that yet. So my personal advice is, especially if you get an exposure, wear a mask. As long as you're not doing anything strenuous, wear a mask. It's not gonna kill you. It's probably gonna save you. If you're sick and you have to go out, wear a mask. But I do not propose patients that feel, or people that feel good enough to exercise, and when you're driving your car, don't be wearing a mask. There's far greater issues. If you can't breathe and you're in your car, you're going to cause a lot more damage to a lot more people than if you're just standing there and wearing a mask.
As far as the masks go, any difference or any cloth mask, surgical mask, N95s, all good, all varying degrees? Where do we come down on that? It's a tough question. I know. I'm sorry.
If we wanted to have the right mask for 100% safety, it would just not be feasible. There's no way we could produce that many. It looks like there was a study done showing N95 wasn't superior to any surgical mask. Cloth mask, they're probably somewhere in between. So my recommendation would be a surgical mask. But if you get to a point where you're sneezing and you think you really need to wear a mask, then you probably shouldn't be going out and being in public and doing all those things.
Right. Doctor, let me follow up on something else. Pre-symptomatic versus asymptomatic spread. Can you go into a little bit on the difference between the terms and what we're seeing from the data on the spread of each of those?
Sure. So we don't have clear-cut data yet. Most patients, the estimate is up to 90% of people that get this COVID virus are asymptomatic or very mildly symptomatic. The question is, like you said, asymptomatic means you have no symptoms. And a lot of patients never have any symptoms, even though they have it or they test positive for the COVID virus. Pre-symptomatic, most viruses you can spread just prior to having symptoms. So that seems to be more likely. The asymptomatic spread, we're still not clear on that, but I think we're starting to lean more towards pre-symptomatic being a much higher chance of spreading it. And this is where it gets tricky with the kids, with the young kids, is if asymptomatic patients can't spread it, then the kids may not be a help to get to herd immunity.
Right.
But for the most part, probably pre-symptomatic can be spread. Asymptomatic, maybe not.
And so I don't know if you have, I don't think I've asked you, do you think the lockdowns have helped, worked, not helped, worked? Social distancing, same questions. Like, are those things worthwhile ventures to continue in some of these places, or is that something that is overreach?
Well, I think this is a glaring example of government hypocrisy. If we're going to allow protests and then we're going to try to spin it that didn't cause any increased number of cases, but we can't go to the bar and sit 6 feet away from the person then the strangers that are there with us, it doesn't make any sense. As far as the lockdowns go, I don't think so. I think, the way South Korea did it, the way that Finland did it, to go through life thinking you're never going to get an infection, you're never going to get an infection bad enough that's going to kill some people, that, obviously Father Time's undefeated. But the idea that these lockdowns are going to somehow help us and not just prolong it. Initially it was flatten the curve, which was admirable.
Right.
But in reality, is it possible? I don't think so. And I don't think the lockdowns really helped. If we look at the SARS 1 data, what did China do to combat that? And, we didn't wear masks for that. How did we get rid of that? Well, the Chinese started washing their hands. They started practicing some social distancing, and the virus went away. It was pretty much that simple. I don't want to bash China too much. My wife's parents came from China, so
I hope you don't have a TikTok account.
Absolutely not. So that's why Shawn and I are friends. We know better. But I think that I don't think the lockdown was the right policy. And actually one glaring fact that I always tell people, and you'll see this in the presentation I gave you. If you want to publish that too, you can do that. Feel free.
Thank you.
In the 3 months after Harvey hit Houston, the number of calls for strangulation by a domestic partner exceeded the total number of calls in 2016. So, and that was a natural disaster. We didn't have any choice. We had to stay inside. When you impose these lockdowns like this for this extended period of time, I can't imagine what those statistics are now. The other glaring statistic, you look at Europe, massive lockdowns. The estimate is at least, and it's probably not even close, 50% more people are dying from heart attacks at home out of fear of going to the hospital and catching COVID, or coronavirus. So, there's a big flip side to this coin, and that's a mental health issue, and that's the other medical issue. You'd think, especially if you look at New York State and how they're reporting all these deaths from COVID, you'd think we cured cancer and we cured heart disease and we cured everything else you could possibly die from. And the only thing that kills you now is COVID. And we know that's not the case. So there's a big impact. And especially with these shutdowns, I don't think it helps the other side of medicine, which is a lot more diseases.
Well, just listening to what you just said, if the number one way this virus transmit is prolonged, very close contact, and the things that are bad for it are sunshine, warm weather, and UV light, am I crazy for thinking maybe locking everybody in their houses together and not telling them to go outside might have a negative impact?
Well, absolutely. I've been preaching that for a long time. And the opponents of that are the people that say, hey, look, it's summertime and the cases in Florida and Texas and Arizona are spiking. Well, again, we can look at the number of cases all day long. If you don't look at the mortality that corresponds, then you're not really looking at the full picture. And the mortality we know is at or below the flu that has a vaccine.
If we can piggyback mental health on, I know gyms are open in Texas. They are not open in New York. What is that like? Are people going to the gym? Is there a sense of being scared going to the gym for fear of transmission? Like, what's happening in Texas, and why would New York have gyms closed? Like, it seems like that would be the opposite of creating healthy people.
Yeah, exactly. And I don't understand that. If you see that healthy people are very mildly affected by this virus, then why not enable them to get healthy? And here in Texas, there's an excellent study done that showed that, going to the gym and working out had very minimal increased risk of even being a COVID case. As we said, cases really don't mean much. But especially, patients that have progressed to have real severe or even moderate illnesses from this. So the data we have is pretty strong and it's pretty good, saying that going to the gym and working out is very little risk to you. And again, the people that are going to the gym working out are the young, healthy ones that are not going to get affected by this. Now, what we've seen in Texas is we've limited the number of spots we have in a gym, and it does it by the size of the gym. The gym I go to is no more than 15 people per hour. So you sign up, the day or so before, and then you go in, and at the end of your hour, you're supposed to leave. Well, the nice thing is, as long as you don't hit that 15 for capacity, you're not restricted to that hour, and they've been, pretty good about that. But even the big gyms, LA Fitness and those things, are doing the same thing down here. And as long as you sign up the night before, you get your spot, you can go in, you can work out. I will say this, it never seems like oh no, I didn't get to go to the gym on the hour I wanted because the spots were all taken up. So I do think there's a fair amount of people that are staying home and are worried about this, which, again, to me, personal responsibility. If you're not comfortable with it, then don't do it.
Listen, I think I'm in total agreement there. If the gyms are open and you don't want to go, you're not actually forced. You can still stay home and not go to the gym. I just think that needs to be cleared up on occasion. Dr. Dunn, let me take you back. You said that when we were talking about how do we get to the point of herd immunity, you said you didn't think a vaccine would be likely to work for this virus. And I wanted to circle back, not to completely shift gears on you, but what can you go into a little more on that? Why would a vaccine? That's all we're hearing about all the time. I mean, Massachusetts just came out with rules that said certain industries will be closed until there is a vaccine. Go into a little of that, please.
So it's not so much I don't think the vaccine will work. I think if you look back at any of these viruses, even the flu, how long it takes to develop a vaccine, and a good vaccine that helps. It's much more than a few months. I don't think there's been a real vaccine out there that's been other than maybe smallpox, and that was simply because if you got the less severe cowpox, you didn't get smallpox, so you just infected everybody with cowpox. But I just think the reality of getting a vaccine out there in a very short period of time, and not having a massive economic impact in that short period of time, I just don't think you can do it. If there's a good, well-studied vaccine, then certainly I'll do it. There was a vaccine trial of 15 patients early, what we call phase 2 trial, and one of the patients got severely ill from the vaccine. So you're looking at 1 out of 15, 7%. That's a real high risk rate for a vaccine. The flu, the risk of a syndrome you can get from having the flu vaccine is about 1 in 100,000. So that's really the risk area you want to be in.
Yeah, I'm no mathematician, but 1 in 7 sounds worse. Just going with that. Along the same line, as far as treatments now goes, we've got a couple of options on the table that I think are showing promise. You're going to have to bear with me as I butcher some of these names. The remdesivir versus hydroxychloroquine.
Both better than my attempts.
I practiced that, just so you know. That wasn't the first try, but I think I got it close. Of what are the treatments that we're seeing now and the impact and your opinion overall on those?
So when this virus initially came out and they were trying all these things, they were trying the hydroxychloroquine, they were trying the remdesivir, and nobody was getting better. Well, a lot of us physicians were saying, of course not. This is late in the course of a virus. Nothing tends to work in those patients. Just like I said, if you don't get your Tamiflu within 48 hours of getting the flu, you're going to get the flu and you're going to be really sick. So we don't have anything now. Actually, we do have something that's been somewhat effective in later disease, and that's a drug called dexamethasone, a steroid. Basically, once we start attacking the body's response to it, we're getting better clinical outcomes. By no means a cure, but better outcomes. But early disease, early to moderate symptoms, mild to moderate symptom patients, especially high risk, the hydroxychloroquine, azithromycin has been shown to be extremely effective in those patients. Remdesivir, we really haven't seen a great study. It makes sense it would, just like Tamiflu. But the big difference is, remdesivir is a patent versus the hydroxychloroquine, which is pennies on the dollar, as is azithromycin.
Hey, so, Dr. Doe, real quick, you cut out there. Could you repeat that part? Right after you were getting into the remdesivir was costing X.
So remdesivir, is an expensive under patent drug. I think I heard once it's like $2,000 for a course of treatment versus the hydroxychloroquine, azithromycin treatment might be $5 for the course of treatment. It's very inexpensive. And as far as we know, neither one is more effective than the other. And we're still not sure that remdesivir has any effectiveness early on.
Okay. What did we miss? What did we need to tell everybody that we didn't cover here? Is there anything that you want to make sure that we touch on before we let you go?
Oh, yeah.
Let's have it.
So one of the interesting things, so we got quarantined, right? We got locked down, and I'm thinking this could be the Spanish flu. So I'm reading everything I can about this because, I'm a bit of a prepper. And so I'm getting ready. I'm trying to figure out, is there anything effective? What should I do? Should I run for the hills? And one of the things we see, one subgroup of unhealthy people that really gets affected by this virus are patients with high blood pressure. And like I said, it gets in through the receptor that we use for the medications to regulate blood pressure. So early on, when we found this out, we thought, okay, let's give these patients that don't have high blood pressure the anti-high blood pressure medicines, and they should do better. And in actuality, they don't. We do them no good either way by giving these medicines. So it's a very tricky, very strange acting virus. And for whatever reason, patients that are already on these drugs that block this receptor still have a worse course than patients that don't have high blood pressure and don't use these medications. So it's a bit of a conundrum to figure out how and why this happens. So and overall, like I said, this is a deadly disease, but the biggest reason it's deadly is because it's new and we don't know the right way to treat it yet. We're learning more and more every day. And what we do know so far is the very young are spared and the very old and the sick are not. So I don't think that the working population, if you look at H1N1, it affected people age 5 to 65. That's the working class. That's going to be a huge economic impact. So you've really got to be careful with that. You look at COVID-19 and it affects people over the age of 60 and people with other, pre-existing illnesses. That's not the working class. There's no reason to kill the economy for those high-risk patients because we know who they are and we know we can hopefully convince them to isolate themselves, as South Korea was very good at, as was Finland or Sweden. So I think there's no reason we shouldn't be able to go back to work, go back to school, and this virus will turn out to be a lot less scary than we think it is.
Dr. Doe, I'm going to leave it there. I thank you for joining us. I hope to be in contact with you, maybe another appearance here on the show as we get some new information, something that we can reassess and kind of pass on to the people will be something in our future. Hopefully, if you're interested and able, that'll happen.
Absolutely. And if you take questions during the show and keep getting the same question over and over, feel free to shoot them to me in an email and I'll try to answer as many as I can.
I very much appreciate it. I will do that. Dr. Doe, thank you for joining us. Looking forward to seeing you again in the near future.
All right. Thanks, guys.
Thanks.
Take care.
Take care. Bye-bye.
Out here.